Good afternoon, everyone. Mm, Thank you for that. Welcome back to the Dean's Leaders in Lanyap lecture series, where where we welcome public health leaders to share their innovations, ideas, and leadership values that got them to where they are today. I'm your host, Thomas Levis, Dean of the Celia Scott Weatherhead School of Public Health and Tropical Medicine. And yes, we say all 10 words. Um, As we get started, I want to briefly ground us in the work that we're here to address and the land that we inhabit. New Orleans, originally known as Bolbacha, is situated in the American Gulf South, historically and presently the epicenter for inequities in our nation. If we are to make our world a more equitable one, we must include and center the places and communities subjected to the largest inequities, in part because the solutions that we seek live in those exact communities. The origins of this lecture series come from a school-wide desire to give our students the tools and experiences needed to become the next wave of innovative leaders. Through these opportunities to meet and learn from some of the most distinguished leaders in public health, we aim to build a bridge between our future leaders and our current ones. This lecture series also boasts something distinctly New Orleanian, lanyap, a concept that you'll find throughout South Louisiana, and is the idea of adding a little something extra or unexpected to an occasion. We have adopted this concept of lanyap by incorporating the arts into this public health lecture series. We hope that after this lecture, you'll take time to discover the art exhibit in the DeBall Gallery right behind us here entitled Echoes from the Hive, which explores the relationships between nature, bees, and systems of food production in New Orleans, upon which we all depend, and created by local urban farmer Carl Harrison. And now let me introduce this month's speaker. I'm honored to welcome an alumnus of the Celia Scott Weatherhead School of Public Health and Tropical Medicine, Dr. Paulin Basinga. Dr. Basinga is Africa Director at the Bill and Melinda Gates Foundation, leading their work across the continent. He brings to his role extensive experience with country and global level engagements, including from his previous roles as the Foundation's Global Director of Program Advocacy and Communications. Before joining the Foundation, Paulin served as Deputy Director of Research at the National University of Rwanda's School of Public Health, where he led the groundbreaking research initiatives addressing HIV/AIDS, tuberculosis, and maternal and child health that contributed significantly to efforts to strengthen Rwanda's healthcare system. Thank you for being here today, Dr. Basinga, and um, thank you for being here, and thank you for returning here home to your alma mater. And I welcome you to address the audience.
Thank you so much. I'll probably stand and make some few remarks before Dean joined me to, for some conversations. But I'm so thrilled to be back in New Orleans. The last time I was here was March of 2009. It's almost 15 years. And I was presenting my dissertation. I presented my dissertation. I remember very well. It was on Monday or Tuesday at the beginning of the week. And I did some research on evaluating the impact of performance-based financing program in Rwanda, which was a large-scale implementation program. And we had the opportunity to work with the World Bank. So the World Bank at that time was funding both the pilot of the program in half of the district. And I just happened to be at the School of Public Health of Rwanda at that time. And I was doing some consultancy for the World Bank. At that time, 2004-05, I was a student here. And I was doing a sandwich program, which was a just masterfully designed program by professors here and the former Payson Center. I don't know how they wrote that grant. You should ask them. Some of them are still here, Professor Bill Bertrand and Nancy Mork and many, many others. And they designed a beautifully crafted grant that the US government funded to actually strengthen the capacity of 3 schools for public health across Africa: the Rwanda School of Public Health, Kinshasa School of Public Health, and the Senegal School of Public Health. So we found ourselves as, we were recruited as teachers in the School of Public Health in Rwanda. So, and we were paired with Tulane so that we can do sandwich programs. So the plan was not to come here and spend 6, 7, 10 years doing our graduate program and then stay here to apply for green cards. The plan was actually to learn, at the same time teach at the School of Public Health and strengthen the School of Public Health. So we used to have professors coming from here to go and teach with us in the School of Public Health. So, but before that, I'll come back to my thesis, but before that, why did I happened to be at the School of Public Health at that time, is that I lived in DRC for the first 18 years of my life. So I'm from Rwanda, but my family was forced to live in exile for long, long time. And unfortunately lost both my parents in the DRC. For people who know and work in DRC, I lived in Ituri, in Bunia. In 1994, the genocide happened in Rwanda, and I decided to just come back in Rwanda because I couldn't see opportunities for me and my brothers as a Rwandan refugee living in the DRC. But at the same time in DRC, at that time, Zaire, we were very well received. I did my primary school there, my secondary school there. But the only challenge was that the opportunity to go and do university from Bunia was difficult. You had to go either in Kisangani, Lubumbashi, or Kinshasa. And if you didn't have family members there or sponsorship, it was just very impossible to do that. But after the genocide ended in July 1994. In September, I decided to just go back home. Without knowing people there, I went through Uganda, traveled up to Rwanda. And fortunately, the government that liberated the country at that time, they had a very clear plan. The president actually sent a group of military to protect the University of Rwanda so that they can start accepting students as soon as possible. I remember that time it was a very controversial discussion because the country was in ruin, and many people were telling the government, no, you should really actually start rebuilding the primary education first before you start thinking about secondary university. And the leadership said, no, we actually need to open all the education system at the same time because we will need those leaders. So in March 1995, only a few months after, the university reopened and applied at the School of Medicine there. And fortunately, I got accepted at the School of Medicine, along with many other colleagues. Probably Professor Janine Chondo, who did the program with me. So we applied, and then we were part of the first cohort post-genocide. We graduated in 2001. When we graduated as young medical doctors, we were sent directly to work in district hospitals. And then I wanted to become a pediatrician. And it was a dream of mine because, there's something about children that just touches every heart, right? Because you think about them when they are sick and you can actually help them. Because children, when they have fever, you treat them. When at that time, we were struggling with malaria, tuberculosis, HIV, diarrhea diseases, infectious diseases. When you treat a child and they feel better, you can see it directly, right? So that was a big reward. So I went in the pediatric department. I was doing my internship there, but we didn't have a residency in pediatrics at that time. But I just wanted to look at opportunities. I was working there, but something was just bothering me because we used to have 15 to 20 kids that will come with severe malaria every night at that time. And I will try to understand and try to collect some few data on those kids, especially the kids that will be discharged, and then they will come back again, with those exact symptoms. Then I will ask myself, what is happening? With some colleagues at the pediatric department, we started going to the community where these kids were coming from and realized there were a lot of stagnant water, etc. So tons of mosquitoes, etc. We start doing very small intervention to try to see if we can actually stop those kids from coming back. Looking at, providing some mosquito net to their families and talking to the public health expert in the neighborhood of those kids and, try to do some public health interventions. We start seeing cases going down. And that was kind of my first introduction to public health. I was like, maybe these things about being in the hospital, you can actually treat more patients. At that time, coincides with this grant that Tulane University had to really strengthen the number of schools of public health. with the Dean of the School of Public Health, the late Dr. Gasakure. They discussed with Bill Bertrand and others. They came and said, we need to actually create a School of Public Health in Rwanda. We used to have a very small public health school, but that was only teaching undergrad students before the genocide. And they wanted to really up the game because we had a very a vibrant School of Medicine with many Rwandans who came back from exile who were really teaching and engaging there. And then the idea was actually to recruit young medical doctors and then young faculties from School of Mathematics and physics and behavioral science, etc., to bring all of them together to be the first cohort of the future teachers at the School of Public Health. And we applied, and I was among among the 10 who were selected to be part of that program. I remember at that time we were barely speaking English, and they had to. But then they looked at what we were doing, and they said, "Okay, no, we'll send you to Nairobi to do some learning on English." So they put us. I still remember that it's called the Yaya Center. I know many people have been here. Probably someone in the room has worked in that program. Book a room there, and they even had difficulties because it was a US organization, but they needed to contract the British Council to teach us English. So we had an intensive 1 or 2 month English, lectures for us to understand, etc. At the same time, I think the late Professor Imon Kelly came, Bill Bertrand, they started teaching us there. We were doing some module. I think Tulane was in the forefront of online training. So they were really thinking about how to use technology back then to really improve the teaching of public health, etc. So we started there. That was our first course, but we were all asking questions. So is this going to count as credit for Tulane University in the US, etc.? It was not easy to get all of us here. And then they found ways to, create a partnership where we can get visas and then come here at Tulane to take credit. So we came to the Payson Center, and we will come for like a semester. And we will spend semester taking classes at the Payson Center, taking classes here, and go back. So I was probably late 20s or 30s at that time for maybe the students in the room. So if you are at Tulane and you live close to the Bourbon Street, you are tempted to drink something. I decided I will not drink while I'm in New Orleans. I will just maximize on my classes. I really, we worked very, very hard, very, very hard on all the classes. I remember very, very well in some other classes, like the multivariate analysis class by the late Professor Susan Rice, we will barely understand all the, we'll bring a recorder to record the class so we can go back, at the library to listen so that we can understand. And we all got A's in the classes, etc. Just hard work really helped us a lot. And also the understanding of the professors. So then that gave us huge opportunity. The difference we had between us and students that were going here is because we had exposure in Rwanda, because Rwanda at that time was rebuilding the health systems, right? So being able to go back home and being part of the program that is setting up the National Health Insurance Program. As a School of Public Health researcher, you have to go and sit in the Ministry of Health and, contribute in the discussions, etc. At the same time, you remember some of your classes that you are taking here about cost effectiveness, about, program monitoring. You pull your slide and then you bring it to the Ministry of Health discussions, etc. So you'll contribute, and then you realize that you are among the smartest people in the room, and then you get contract, etc. So that helped us a lot. And then you'll come back here. I remember one of my class on, let's say, evaluation. Dr. Gage used to give us, like she'll download data from DHS. I remember one day she gave me a DHS data from Zimbabwe. I did the analysis. Then I came to her. I say, by the way, I'm working on a real program in my country. Can I use this data to do exactly the analysis you are asking me? And then, use that as my credit. She said, yeah, if your data is clean enough, I'll accept it. I said, okay, go. I tried to run the analysis. It couldn't work. I came back to her and I said, no. Before you do the analysis, you need to clean your data. Yeah, so but then I went through that process, cleaning the data and then analyzing the data, learning my multivariate analysis or anything that was, and then I got my input from a experienced consultant in the US, brought it back home so I can present my research there so it can change policy. So we were gaining grades, changing policy at the same time, and then teaching our students at the School of Public Health, because Tulane did this amazing program to match us with professors so we can take classes here, adapt it in Rwanda, and move forward. So fast forward, then I find myself, really running one of the biggest evaluation of quasi-experimental design funded by the World Bank in the Ministry of Health. And then one day I asked them a question. I'm about to finish my PhD. I'm looking for a thesis. And we were discussing almost 2 different topics with many professors here. Then when I explained, they said, no, you can actually use this because you've been working on it. And then it was a really great partnership. That flexibility between the Pearson Center, Tulane University, and the University of Berkeley helped me to actually finalize my thesis very quickly, and we published it in the Lancet, and it changed policy across many countries. And then when I made my defense, I remember I spent almost the whole day after the defense with Dr. Gage to correct everything, submitted on a Tuesday, had my flight on Wednesday, went back to Rwanda. When I got to Rwanda, they said, okay, now the professor who was leading the School of Public Health, the deputy director, needed someone, and they were just waiting for me to qualify and have a PhD so that I can be in the leadership of the school. And that was the beginning of my career. So I became the deputy director of School of Public Health. Then we had tons of partnership with many universities, many partnerships, etc. Worked there for 3 years, and then got recruited by the Gate Foundation when Professor Stefano Bertozzi, who we worked together on my PhD as well, became the director of HIV at the Gate Foundation. And then back then, the Gate Foundation had no office in Africa. And I remember he was traveling with Mr. Gate in South Africa, and we're talking about the effectiveness and efficiency of HIV programs, et cetera, at that time. And then, he asked, do you have Africans who understand the program, et cetera? There was Dr. Leon Kisi, who is from the DRC, who also did his MPH here, who was working at the Gate Foundation. So they opened that position. I applied, moved to Seattle in 2012, and started working on that program. And then after that, we started really asking some fundamental questions, because the Gate Foundation model of development was all about really creating global public good and let the world to actually take that up, right? So, let the US government, the UK government, et cetera, actually pay for scale, because the Gate Foundation would come up with innovation, test it, and then, things will be uptaken. But we realized that while for some program that was working, but for most of the program, the bulk of innovation that the Gate Foundation supported didn't actually got adopted because of the lack of understanding of the context in each country, or the scale didn't really happen. So we realized that it was really important to start opening offices. So the Gate Foundation opened the office in Nigeria, South Africa, and Ethiopia, where we had some of our biggest program. And then I moved from the vertical program to mostly horizontal program at the Gate Foundation, the integrated delivery teams. And then I started actually being part of the teams that really pushed and supported the expansion of the Gate Foundation program on the continent. I moved back to Rwanda for a year because they called me to help them support the design and implementation of what we call the Rwanda Biomedical Center. For people who work in Rwanda, they've actually cut the verticalization of program. They've created one organization which is in charge of all program implementation, the Ministry of Health. When I came back to the Gate Foundation, that was actually the turning point in my leadership career. So they asked me to now become a deputy director to help us engage and develop our program in Ethiopia, Nigeria. And then later on, I'll move with my family in Nigeria to lead the Gate Foundation office there, where we were working on polio eradication and health system strengthening the northern part of Nigeria, including also agriculture development and financial inclusion for the poor. All those programs that are beyond health, because the determinants of health are, massive. And those are all the lessons that I learned from Tulane, because that, the degree on international development, all the courses we took on, developing agriculture, water and sanitation. I remember going back to my note from Professor Basinga is to get the latest book and try to really understand, development in general. That really shaped my career. And also the leadership lesson that we learned from here. I remember some of the lessons that we learned from Professor Bill Bertrand, how he was teaching us how to write proposal. That continued to be something that, as a grant maker today, I look at it. He was used to teach us that grant proposal is like going to war. Like he gave us the 10, continue to do that, the 10 rules of how to win a war. You really need to understand your enemy. You need to understand their strategy, what they are optimizing for, so that you can actually shape your proposal in there, etc. So how to write a perfect budget, how to understand program implementation, etc. Those are all the lessons that I learned from here. And then also just leadership, how to build teams, how to build strong teams, etc. Then, fast forward, I went back from Nigeria. After Nigeria, I was there during COVID time. And then the foundation actually saw how I was able to understand, both the global engagement, country engagement, and they needed someone to move back to Seattle to lead our global program advocacy team globally, which really gave me even broader perspective to understand how to advocate for Gavi and Global Fund or CGR that is supporting agriculture development research across the world, etc. And I did that work till when the Africa director retired, and they asked me if I would be interested to apply for the role of the Africa director for the foundation, because the next phase of the foundation, as you know, the foundation is turning 25 next year. So the next, 20 or 25 years, a lot of focus will be in Africa, because when you look at the burden of disease, you look at the potential of economic development is still in Africa. So we decided to add 2 more offices in Senegal. I was there 3 weeks ago with our leadership to open a new office. And then last week, we just opened officially our office in Nairobi. So now we have 5 offices in Africa. So I'm just moved my family from Seattle back on the continent. We are now in Nairobi, and I'm leading the Gate Foundation operation from Nairobi, but also we have leaders in all those countries and trying to see how we can actually continue to be relevant in this new world of multilateralism, which is being questioned, the world of decolonization of global health and global development. What does that mean? The world where Africans need African solution to their programs, etc. But at the same time, they still need capacity, where you here in the North, you actually need to also adjust and adapt in terms of how to continue to be relevant. I think probably I'll stop here. I can talk and talk, but I'll be happy to respond to questions. But just again, to close by saying, Dean, I'm so thrilled to be back here, just working. Yesterday, I came just to work here to take some picture. I redid some of the work. I'm going, uptown tomorrow. Just it's bringing a lot of memories, and you all are very, very lucky to be part of this community. And the fact that all our professors are still here, it means a lot. I think I came to just show them that the impact of sometimes what you do in a classroom, when you sit with a student. Dr. Gage used to write, because we're writing very good topics, but with a bad English. She used to, to say, I apologize. There's a lot of red in your paper, but it doesn't reflect what you think. But it's just here in America, you need to actually to write good English. I hope if I could redo my courses today, I'll improve my English. But thank you for it.
Well, thank you for that, and welcome home. Welcome back home. So you talked a lot about your rise as a leader, and it seemed like a lot of times things sort of happen, things come your way because people see something in you and then offer you opportunities, and that seems to have been the way things have gone. What do you think it is that people are seeing? What is it, and what can you tell our students about what they see in the way that you're showing up that's making people say, "Oh, that guy's the leader. We should maybe make that guy the head of whatever, of the variety of places that you've led." What are they seeing? What are people seeing?
I wish they were here and they will respond to that question.
I know.
Because I don't know.
I know.
But I can just probably share my own philosophy in work, what I do. So and I'll put it in a way that it will really help students actually to understand, because the current students are living in a fast-paced world. Like, things are moving very quickly. And, when you are on social media, you can, scroll or sweep very quickly, and you think that things will happen. I always take the long-term view. And I think my philosophy of work is, when I'm doing something, either it's global public health in the University of Rwanda, is to actually understand the mission of the organization and put 100% on the current thing that I'm doing.
Mhm.
And I don't think about, is this going to help me take the bigger job, etc. I'm
Right.
like, I'm in charge of this. I'm
Mhm.
going to really understand what the organization wants to achieve, what is the mission of the organization, and I'm going to do the best that I can to actually make that organization that shine.
Mhm.
Just to give you a concrete example, the School of Public Health, for example, I was discussing with some colleagues here and realized that like grant making, it's a big challenge. I remember when I was the deputy director in charge of research at the School of Public Health at the University of Rwanda, I started asking this fundamental question that was back in 2010. Why is that we at the School of Public Health, we can't get grants directly from the US government, while the US government has an office in Rwanda? Why is that? And I realized that I started doing a lot of research to read the laws. I realized that there was nothing that prevented us, but we needed to do some work. And then I used some of the university money to hire a grant manager at the university. I went to visit the US ambassador, the head of, CDC. Her name was Pratima at that time. She was there. I said, no, I need really to understand. And then they brought me in, gave me tons of material, how to apply for a DUNS number, etc. So I made sure that the School of Public Health in Rwanda was eligible to receive money from the US CDC in Rwanda. So when I did that, and we received 5 million grant back then to actually build and strengthen the capacity of the School of Public Health to do pandemic preparedness and train PhD students, etc. And when I saw that, I was just doing my job, because I say if you are in charge of consultancy and research, you need to raise money for the university, etc. And then that's really positioned myself, etc., to move on. So just what you have to do it well, etc. And then the second one is just to understand the why. Sometimes we think a lot about ourselves, but we don't think about our field of development and field of public health. It's about doing good. It's about, and I learned this, again from the M&E class here. One day it really opened my eyes, and I kept that mindset, right? Because we talk a lot about, policies and processes, etc. But you still always to think about everything that you are doing. There is a trajectory to really reach true impact in the people's life. There are a lot of inputs, like many people stay in the inputs. I've published a paper, I've trained people, those are all, like the processes that get you tons of input, you get money, etc. But you need output from that. You need concrete things that your program will do to actually say there are X number of people who have been trained. There are, X people who received, reached by the services, etc. But that, again, is not enough. You need to actually realize, is that actually changing people's life? Are you increasing coverage of services in the community, in the catchment area, etc.? And then even that, it's enough. You actually need to know if your program is actually having concrete impact in reducing infant mortality, maternal mortality, nutrition, or providing people economic opportunities and lifting them out of poverty. So I try to connect that link always in the grant that I make, the work that I do. And when your leaders see that you have that true line to sustain impact, I think, and when you make your decision based on that, and then realize that it takes time, and it's not about yourself, it's about partnership and collaboration, working with many people, bringing people together toward a goal. I think those are leadership skills that people will see, and it will just continue.
So I heard several things in that answer, and I want to just highlight them because I want to make sure that they were on the table. So what I heard in that answer was you need to be strategic, right? But by that you're talking about focusing on the outcome, the objective, what it is you're trying to accomplish. Now there's a process that has to happen, and of course you need to be mindful of that process. You need to be focused on that process. But if you remain focused on the outcome, then people will understand that's what we're trying to get to. I also heard strategic thinking, right? I also heard collaboration and bringing other people into the vision for what you're trying to accomplish. And I also heard that you talked about the need to focus on the present, the here and now. So you're not thinking about what's the next job, right? You're thinking about, let me be excellent in the current position, and then people will see the potential of it. Okay, so let me ask you, I guess, the corollary question. Now you are a leader. Now you are managing other people, and you're assessing talent around you. What are you looking at? What are you looking for when you're looking at the people in your organization, the other people around you, for future leaders that you want to provide opportunities for their evolution, their development?
Oh, thank you very much for the great summary. It's exactly it. We at the Gate Foundation, we are a private philanthropy,
Mhm.
and we, when you work for a private philanthropy and we are a donor, it's a very, very difficult job, not in terms of the content, but in terms of how you are perceived. Because, sometimes anything you say, people either from grantees and public health, etc., they may just agree with you because you become pseudo intelligent. They show you that you are intelligent because they're in that game of grant, right? So they are, they are.
You're saying people are happy to see you when you walk in the room? Is that
People
is
are
that what
very
you're
happy
saying?
to see you.
Yeah, yeah.
When you send an email with your Gate Foundation email,
They
you
respond.
get a response, always. And
So it's
people
hard to
want to
give
learn
away
from you.
money.
Exactly, yeah.
Okay.
But for me now, as a leader, I try to look at the staff at the Gate Foundation. The staff has potential to work as a great Gate Foundation employee is someone who's able to actually distinguish the noise from the truth. Someone who can actually, bring knowledge, content, but at the same time, the understanding of the field in a way that they create genuine partnership with our partners and grantees and government, so that you are not seen as a funder, you are seen as a thought partner, so that you can actually build those coalition, and you can say openly, the Gate Foundation can fund this or not, without wasting people's time. Or when you see a potential, you can actually collaborate and move very quickly to something very concrete to help the partner to actually do the work, etc. So I look for that potential for me, that one. And then within my team, people who are already working in our team, I look for problem solvers. So people who always come with a problem, but with 3 possible solutions. Say, I'll try this one, and then etc. And and then collaborators, people who will share credit, people who will say, you know what, I think if we partner with so and so, we can actually come up with a better solution, and this is what we're doing. So when I see that, I actually follow those people because you can see a potential leader there. Yeah.
So I know in the conversation we had earlier, and you even mentioned it here in your in your remarks, you mentioned other students that were in the cohort with you, right? And how those relationships have continued over the years. Talk a bit about that, and what advice would you give to the students here about the importance of developing those relationships now while they're still in their training?
Yes, no, but I think we were a quite different set of core, because we came at Tulane with programmatic experience, right? With partnership with Ministry of Health, etc. Both in DRC or Senegal, and here I continue. Professor Didine Kamba, for example, is at at the School of Public Health in Kinshasa. I continue to do amazing work. I met with another professor in Senegal who doing who lead the School of Public Health there. It's alumni from here, but it's because we had those partnerships with the program people. But if you don't, I will say really do your best to connect with the program, because theory alone will not get you there. And program implementation is everywhere. It's here, in your backyard. There are public health programs that are being implemented every day, and they're looking for volunteers, people who have interest, right? So go to any organization, local public health organization. I remember during COVID time, for example, we had many School of Public Health students who actually volunteered to go in the Department of Health to actually help. If you can go understand, even if you understand how the program is designed, how it's funded, which source of funding, how they report, how do they bring policymakers, how do they evaluate their programs, etc. That will help you in a big, big way. So here, and then internationally, if you are able to go and volunteer and partner with local NGO, international NGOs, If you are from, in Rwanda, I just met Gloria from Rwanda here, who, is in a great university, University of Global Health and Equity, which was created by Professor Paul Farmer. So I sit on the board of University of Global Health and Equity. One of the things that we're pushing the university is university need to work very hand in hand with ministries of health, because when you apply actually your research into the program at the Ministry of Health, both at the national level or subnational level, you actually learn, because when you go to any international, program like either Global Fund or PEPFAR or PMI, etc., all those programs land in a district somewhere, because your contributions will make a huge difference. Because in addition, you not only have programmatic experience, but also you have that evidence-based ways of thinking about things, about how to include, high impact intervention to programs, etc. So I would say, try to get some hands-on experience and read a lot. Today there are different ways that you can actually absorb a lot of information.
So there's a lot happening on the global health scene right now. A lot of talk about decolonization, localization of funding. What do you see, of course, climate change and the way it's impacting really the entire planet, but certainly in the global health space, it's a topic that comes up a lot. We just had ASTMH here. These issues were coming up a lot. What do you see as the as the most pressing issues for global health that this generation that's training now is going to be facing in the next few years?
Thanks for the question. We grew up during the golden age of global health. Money was not a big problem back then. 20 years ago, with the creation of PEPFAR, that was one of the biggest impactful programs that this country, all the taxpayer here, you've saved, tons of lives. When I was doing my medical school, by the way, in Rwanda, we used to have a room, like it was for 60, I remember very well, La Salle 4, it was, Salle 4 in CHUK, it's the teaching hospital in Kigali. We had 60 beds, at that time, we used to have, 120 patients there. Then you'll put 2 patients in one bed because of TB and, HIV. It was huge, no ARVs, etc. But now it's gone. The impact that PEPFAR has had, the global funds, PMI and Gavi, huge. But what we are seeing today is, even when you look at global health, you look at the data, the underfed mortality has been decreasing for the past 20 years. It has been half by half. And maternal mortality, same, but there's been a plateau since in the past few years now. So there is a need to really rethink global health. At the same time, one of the biggest challenges is actually the macroeconomic changes that are happening. Countries in Africa are paying more on, paying back their debt than, like the interest rate is huge because they have to borrow from, China, from, private market, etc., to continue to fund their development. And, they are paying, not only on interest rates, it's bigger than some of their, budget on health and education. When you go into Ministry of Health, government cabinets today, they're actually looking at, in terms of looking at what are the programs that we're implementing, they're looking at what are the bonds that are due now for maturation that they need to pay. It's a big issue. Number 2 is aid is decreasing significantly. In the past year, we used to have 25% of all ODA going to Africa. Now it's only 15% because countries, UK is cutting their aid, France is cutting their aid. In the US, we're all, looking to see what the new government, will do in terms of their contribution, Gavi and Global Fund and WHO. It's very threatening because the aid has been really helping in a big way to make sure that government in Africa have money to support their health systems, etc. Pay for commodity, for family planning, for HIV, TB, malaria, etc. So that is, becoming a reality now, while government has difficulties to raise more money. At the same time, there's a huge challenge with climate change. As we saw in, here, the impact on climate change in health is huge in terms of, malaria, in terms of agriculture productivities, so a lot of stress. And then Lastly is all the debate about, multilateralism and, need for African countries to actually have African solutions. One thing that happened during COVID was quite telling, because African governments, even though some of them had money to buy for vaccine, they couldn't get COVID vaccine. It has fueled a lot of debate, discussion about the need for African to be resilient and to be, to be able to produce some local product there, including vaccines as well. A lot of discussion about that. The Gates Foundation is working with Institut Pasteur de Dakar, for example, to build capacity. But the reality is that to be able to do vaccine manufacturing, it's a long-term play. It's quite challenging, it's difficult, but there are some, basic manufacturing that Africans can actually start doing now. The Gates Foundation is funded by the way, a company in Kenya, in Kilifi, called Revito, to actually produce, syringes for vaccination. Actually, in Africa, instead of importing syringes from India, now we can actually produce from Africa, etc. So I think for Tulane and other universities here, just to think about what is your position on all those different challenges, like how do you position yourself to continue to be relevant, and then also really finding ways to create those very genuine partnerships, because Africa can't do it alone. They need the know-how, the technical know-how from here, but at the same time, we need to think about efficiency in terms of the small amount of money, because I doubt that we'll be able to increase the aid or money that will go to global health. But even if we can maintain that, how do we use the new artificial intelligence thing that we are seeing, how to do things faster, cheaper, better, maximizing the existing money that we have today, but also putting more and more local partners, local universities in the forefront, but at the same time using the years of experience. As I was preparing for my speech at the STMH, I was just thinking about, wow, this society has existed for more than 100 years. I don't think we have, something like this in Africa. There is knowledge here for years, but it's time actually to rethink the model and say, how do we change partnership and create those new partnerships for the next 20 years?
Okay, we're gonna open it up to the audience for questions, and while we get settled and get ready for the first question, I'll ask you one other question. This is going back to a conversation we had at breakfast. We were talking about the new administration, and you just made a comment about PEPFAR and how U.S. taxpayers supported that and the impact that it had. Make the case to the new administration about why it's important for U.S. to be, a major donor and a major player in the global space. Why is that important?
Well, look at the camera and then talk to the new administration.
You can look at me. It's fine. It's fine.
No, I don't know if how this will play out, but as someone who has seen the impact of U.S. government contribution to global health and global development, I can say it has made the world a much better place, because the U.S. government is the most generous government in the world. When you look at when you look at the contribution that the U.S. government has made in global development in general, it's massive. In terms of the Global Fund, it's a third of the Global Fund, for example. Gavi, huge contribution. The support that the U.S. government gives to American institutions to actually support work, etc. It's huge, but at the same time, it's a small fraction of the U.S. GDP. It's a very small fraction, but the impact is huge. And the case I will make is to say that, if you want to make America great and America first, there are ways that you can make it in global health. A quick pitch that I would have is to say, just think about one case of, because we are now living, regardless of people's understanding of globalization, we're living in a global world, like we're all together in this. And we know that the likelihood that the next pandemic or the next outbreak of diseases will come from, countries that have weaker health systems, that has weak One Health policies and programs, etc. And, people travel. We can't close. Like, We can control immigration, but it's impossible to control people. When you look at how massive the US is, all the entry points and how many people travel in and out of the US every day, including Americans every day. So something will come here. And when a virus comes here, either Lassa fever or Marburg or Ebola or anything, the cost of controlling contact tracing here, it's very expensive. But at the same time, if you actually help a number of countries in Africa for them to build much stronger, disease surveillances, etc., the probability of detecting the threats and the disease and controlling it there, it's a business case for the U.S. government to actually, strengthen the capacity of countries to detect threats very quickly, to control it. When you visit, you go to any country in Africa, you visit the offices of US CDC. I was in Nairobi, I met with the ambassador, I met with the head of the US CDC program there. Massive operations across. I think just continuing to fund the US CDC, the work that they're doing in different countries to strengthen epidemic surveillance and also to support USAID on health system strengthening and support, Gavi, Global Fund, etc. It's a small contribution, but it's a huge play for the, keeping US safe.
Okay, well, I'd be happy to keep going, but are there any questions in the audience? Yes, we have one here. Well, we need to use the microphone because there's people online.
Hi. What do you think will be the influence of Melinda French-Gates' departure from the foundation on its future support of family planning?
Yeah, this is a question that we'll get from Jane Bertrand, who has been in the forefront of family planning and reproductive health in the world. Now, I would say, Melinda, as you know, Melinda co-created the Gate Foundation with Bill, and they ran the organization for many, many years. And we were all really touched by her decision to leave the foundation. But when she talked to us as leaders of the foundation, she felt very comfortable that the foundation was at the place that, really good in terms of setting up the direction for family planning, for reproductive health going forward. And she left the gender equality division led by Anita Zaidi, which is strong. We've moved in the gender equality division where women's health is actually managed out of that division, with the director of family planning, MNCH, women economic empowerment, women in leadership, they're all part of that division. It's one of our biggest divisions as well in terms of budget and strategy. And, it's continuing. That commitment is clear. I just, on my, 1 week before here, I was just reviewing the grant that we're making in Ethiopia, for example. We've picked a number of countries, Nigeria, Ethiopia. We're being very targeted in terms of, I know, some of your colleagues here work on our family planning programs there to really, pick a number of countries, look at, MCPR and try to see what are the strategies that we can implement to actually increase MCPR in the long term. And we're making significant investment, working with different partners, et cetera, to actually drive that. So we are very comfortable and confident that work on family planning will continue. We will definitely miss Melinda's voice as a family planning champion in a big way. But we are also thrilled to see what she's doing now with Pivotal. She will continue to drive impactful work, and we are hoping that even now she'll continue to be a big voice that we can ride.
Great. We have another question here.
Hi, I'm a student in the MPHTM program. I was wondering if you could comment, personally, I see that there's a lot of sort of shared challenges between Africa and the United States and sort of the world as a whole. When you kind of look at issues related to stigma towards people who are in poverty, stigma towards people who are LGBTQ, these sorts of issues. And I was wondering if, from your experience as a physician in pediatrics or as a leader in global health, what you see as kind of the impact of that stigma and how we can kind of combat it moving forward.
Oh, thank you for that question. Stigma, it's a huge issue because it can impede into the introduction of new products, the adoption of products and program at the community level. I think one lesson that I've learned is just to really make sure that you engage local community early on, and then you speak in their language so that they are going to be the ones actually to drive the program adoption and implementation. Because stigma starts when there is a lack of trust from the local communities at the beginning. And now, the other thing which is being, not at the same level, but as complicated is the impact of misinformation as well. Misinformation, with the rise of social media, also it's, impacting program in a big, big way. This is why even when you are thinking about programs in partnership, like really starting to work with local organizations early on, very, very early on. In most of the grants that I review, I try to make sure that the local organizations are not listed as sub-grantees, where you have your conversation before with the funder, then you finish, you get all your grants, then you start now bringing the local organization later on. This is where some of the mistake comes from, right? But when you start actually in the design, working with the local organization from the get-go, even being applicant with them at the same time. We know that there's some challenges. I think that really helps solve some of the problem. I'll not say it's all of the problem, but it's a very difficult position. But one thing that we've seen is in programs where the local partners have taken the leads, because if you remove the notion of this is being transported from the north to the south, because this is a big word, stigma become a big issue. But when the local organization can actually say, no, when I go back to Rwanda history, I can read that the homosexuality is in our history for a long, long time. But you can't say it that way. You need to actually get some people to really understand, and then find appropriate, culturally appropriate ways of discussing specific issues. Yeah.
Mhm.
Hi. I was curious because some of the problems that we've been talking about so far have been really focused on communicable diseases. And so I was curious if you could talk a little bit about the landscape of non-communicable diseases, motor vehicle, deaths and injuries, and how that plays out in like the African context, and what are, some possible African solutions for these problems as well.
Yeah, thank you very much. We looked very closely at the IHME data on the burden of disease to actually, track both, cause of diseases and also the determinants of burden of disease, etc. And the, motor vehicle, it's huge, including it's a big issue. And sometimes we do all the intervention that we have to do, vaccinating kids and making sure that they get all the intervention, etc. They go to school, and to lose them for a lack of the right policies, etc. It's a big issue, and I think it's something that we are doing our best to advocate for more multi-sectoral collaboration to advance population health in Africa. And we've seen it in few countries. A country like Rwanda, actually, they've improved significantly, because in Rwanda, for example, the Minister of Health worked very closely with the Minister of Justice, Minister of Agriculture, local government, and the police to put in place even regulation, simple regulation, as the motorbike need to have 2 helmets with them, so that many accidents come from actually the motorbikes, etc., because people don't have helmets on, etc. So that multi-sectorial collaboration is critical, but the big challenge is getting the right leadership in those ministries for them to actually bring their colleagues together to create those laws that can go to parliament, can go to the ministries. But it continues to be a big issue. And then at the same time, as donors, many donors actually, because of the limited set of resources, we tend to actually focus on fewer issues to drive impact within our own issues. And sometimes we don't look up to actually understand what is happening at the country level. Only if the government actually pull people together to pass those laws, that will really help.
Hi, thank you for your presentations and your insights. I wanted to circle back to your experience as a leader and a partner with African universities. And the model has very often been that a given university in Africa is going to have a, let's call it, privileged relationship with a given university in the US. Rwanda School of Public Health, and even perhaps more so KSPH, have very strong relationship with Tulane. Makerere has a strong relationship with Karolinska. And Dean Mashinda of KSPH was here last year, and he kept underlining the fact that we need to find ways to develop partnerships between universities on the continent in order to leverage all the resources. And in that perspective, what is the role that Northern or Global North University can play to help leverage those partnerships, even if that means relinquishing part of their privileged relationship with some of those universities? Thank you.
Thank you. We discussed this morning with the dean, you know, you are spot on. You know, I remember when I was at Tulane, I was struck by something that happened here during, it was not during Katrina, 2005, it was the hurricane before Katrina, 2003, I think, 4. Ivan, it was during Ivan. We had to, you know, they split us in different universities, right? So even at that time, there was an electronic system. And because of the partnership that Tulane had with John Hopkins and you know, different universities, they split us. So we were able during the semester to take courses in those universities. And then the credit was taken back. I'm not going to tell you which university we were all fighting to get into without applying, etc. So, but it was just that great partnership with Northern universities, you know, stayed with me. And I agree with you that in Africa, we have Association of African Public, public health schools. So the deans are coming together. I'm also discussing by the dean of the University of Global Health and Equity. They are planning to organize a meeting next year in March, to bring the deans of School of Medicine to think about how to work together. So I was even, sharing with my team that this is some of the partnership that we actually need to fund to make sure that they all come together. So they need to really strengthen their partnership, but also move the partnership between individual researchers to have partnership with universities. This has been a huge challenge, to actually, create partnership between institutions. The big challenge also we have in Africa is, is that all the schools don't have, I need to be careful what I say here in terms of, because like in the US, you put in place structures and mechanisms so that if a PI, bring a grant to the university, it's clear, what is the salary range? What do you use for program? And it's so clear. So you'll be able to actually operate. I'm not saying that it's simple, that, you have to go through bureaucracy, but actually if it's a grant to achieve an objective, it will run down. But in some African universities, it's very complicated. When I meet with head of public school, because as a funder who used to be at the School of Public Health, I say, I'm willing to give a grant to the university, but at the same time, you should commit to actually deliver. If you don't deliver on time, if you don't write a proposal, it will not work. Like you actually need to deliver, etc. So I think we need to strengthen, schools of public health ability to actually operate independently, also strengthen their partnership with other schools of public health. I think if they can create that partnership, then they can actually have a much bigger case to negotiate with, many universities in the North, etc. Fully agree with you. So one way that we're trying to do that is, first to create a database of all universities in Africa with their capabilities. In my, speech yesterday, I shared a link at the website that we are working with the African Population Health Research Center in Nairobi. They've created a website, a database, been doing 2 years working with them. They're going to launch it officially sometime next year, so that at least in the North, you can actually go into the website and, see where are the universities in Africa, who are the PIs, what are their publication PubMeds, and then, what are their contacts, etc. So that should be visible for everyone. So I think if you're applying for NIH grants that need one university in West Africa, one in Southern Africa, one in East Africa, you can actually compare and then reach out to them, etc. So that is one service that APHRC will be providing. But also the association is so critical. So if we can help in any way to strengthen those collaboration, I think that will be. And the last thing I would say is, it's not just the partnership for the sake of partnership. You need to anchor it in some very concrete deliverables and then link it to some, education program. Like if you can I did some program with a number of universities in Ethiopia to do an evaluation of, integrated ICCM, integrated community childhood. Oh, I forgot what the thing, like community case management of childhood illnesses, right? So doing an evaluation back then, and then we get a grant to PATH and UNICEF. And then I told them, you should actually work, because they was proposing 4 regions. I'm saying, can you pick one university in the 4 regions, select them, but then in the grant, try to get a PhD student who will be using the data for their PhD, because I was using my own experience, and it worked beautifully because it was training, partnership between university and implementing partner, getting a PhD who are actually going to spend nights because they will get something out of it. If they don't get something out of it, and then it worked very well. When I go back, I meet those university students. Now they are professors at the school. They've published. We got the evaluation of the program. We applied for the money, the ministry, etc. It's kind of like being able to create those networks. Yeah.
Okay, thank you. This has really been a lot of fun and fascinating, but unfortunately, we are out of time. We're going to have to close out. So thank you, everyone, for joining us today, both online and in the auditorium. And a big thank you to Dr. Basinga for joining us today. That's a couple of quick announcements before we depart. We hope you'll mark your calendars for the next Dean's Leaders in Lagniappe lecture on Wednesday, January 15th. We'll be joined by Dr. Perry Hilgaskis from the Rutgers University School of Public Health. And I also encourage those of you here in person to enjoy a bit of Lagniappe in the DuBois Gallery by taking a look at the exhibit Echoes from the Hive and joining us for lunch beginning now.